Hello everyone. We're the group 4 and we're going to tackle anemia associated with abnormal iron metabolism. Together with my group mates, Apino Farema, Morapao Princess Nicole, Demasa Lane, and Hata as Inaglisari. I am Crizia Lorraine Cañete and I am going to tackle this first topic, the iron metabolism associated disorder and the heme disorder. First is the iron metabolism associated disorder. We have the subtopics: the iron and its metabolism, the iron deficiency anemia, and disorders of iron excess. So iron and its metabolism are vital in the body because the hemoglobin molecule is non-functioning without iron, and 2/3 or more of the total body iron is in the RBC and their precursors. So the iron deficiency anemia is one of the most common forms of anemia in United States. Next is the disorders of iron excess. It is a result from the slow accumulation of excess quantities of tissue iron stores that can result of increased intestinal absorption. Okay, iron and its metabolism. Each milliliter of RBC contains 1 milligram of iron. Storage iron is present in macrophages or normoblasts as ferritin or hemosiderin. So ferritin, it is a storage of iron. It is a blood protein that contains iron. Storage, the majority of iron used in hemoglobin synthesis is from the iron released and recycled by hemoglobin that is degraded in macrophages and transported to normoblasts by plasma transferrin. From the word itself, transferrin is a transport iron through the blood to various tissues such as liver, spleen, and bone marrow, and it plays an important role in iron metabolism. So only 0.9 to 1.3 milligrams of iron per day is lost from the body. The small amount of iron lost from the body is maintained by dietary absorption, which amounts to approximately 1 milligram per day. So we have this dietary iron average for men and women. For men, we have 15 milligrams per day with only 6% intestinal absorption, and for women we have 11 milligrams per day with 12% intestinal absorption. Dietary absorption is increased in an iron deficiency state, but only to a maximum of 20%. So the dietary iron is digested in the ferric form, but is reduced to the ferrous form in the stomach by HCl and other reducing agents. The ferrous form is much more rapidly absorbed by the mucosal cells than the ferric form. So once in the mucosal cell nausea, the ferrous form is oxidized again back to the ferric form and coupled to the protein apoferritin to form ferritin. So nga na lang siya na from our previous chapters na natakal na nato, we have to maintain ferrous state sa atong RBC nga iron kay so that it can bind to oxygen molecule kaysa sa ferric state. So iron enters the circulation bound to transferrin. The normal serum iron concentration is 50 to 150 milligrams per deciliter. The normal total iron binding capacity, or TIBC, of transferrin is 250 to 400 milligrams per deciliter. The transferrin is normally only 30% saturated, and the serum ferritin is concentration is normally 15 to 200 ng per ml. So the normoblasts in the marrow have transferrin receptors and the capacity to extract iron from plasma transferrin. The marrow receives only 5% of the total cardiac output, but it extracts 85% of the circulating iron. Iron is also transferred to normoblast via the nurse macrophage. This nurse macrophage assists in the development of the red blood cells.
Iron deficiency anemia or IDA. IDA results when iron loss exceeds iron intake for a long time, and the body's iron stores are depleted. The development of IDA is seen to occur in 3 stages. Patients who have IDA are initially seen with the clinical symptoms. Laboratory diagnosis of IDA demonstrates characteristic findings in the blood and bone marrow. IDA must be differentially diagnosed from other microcytic or hypochromic anemias such as thalassemia, anemia of chronic disease, and sideroblastic anemia. These points will be tackled as we go along. IDA results when iron loss exceeds iron intake for a long time, and the body's iron stores are depleted. Insufficient iron is available for normal heme production. Iron deficiency develops when there is an increased need for iron, such as in rapid growth in infancy, childhood, or during pregnancy. IDA is the most common cause of anemia in children who are between the ages of 6 and 24 months. Iron deficiency also develops when there is excessive chronic loss of blood. In the adult man, even with no dietary iron intake, body iron stores of 1000 mg would last for 3 or 4 years before iron depletion anemia would occur. Most cases of IDA in adult men, therefore, are attributed to chronic blood loss. The development of IDA is seen to occur in 3 stages. First, the iron depletion stage. This is the beginning of iron deficiency. When iron loss exceeds absorption, a negative iron balance develops and iron is mobilized from iron stores. When this process begins, storage iron decreases, plasma ferritin decreases, gastrointestinal or GI iron absorption increases to a limited extent, and the amount of plasma transferrin increases. Iron deficient erythropoiesis stage occurs when the tissue iron stores are depleted. When transferrin saturation falls below 15%, the percent of marrow sideroblasts decreases, and as a result of insufficient iron for heme synthesis, the serum iron is decreased and levels of RBC photoporphyrin increase. Lastly, the IDA stage is a clinical anemia become detectable first as a normocytic or normochromic anemia, then gradually progressing to a microcytic or hypochromic anemia. Patients who have IDA are initially seen with the following clinical symptoms: numbness and tingling of extremities, atrophy of the epithelium of the tongue with soreness, cracks or ulcers at the corners of the mouth, abnormal cravings for such things as dirt or ice, concave or spoon-shaped nails. Laboratory diagnosis of IDA demonstrates characteristic findings in the blood and bone marrow. Laboratory findings from a peripheral blood sample include the following. Early stage of IDA may demonstrate normocytic or normochromic RBCs, but this eventually develop into microcytic or hypochromic RBCs with marked anisocytosis and slight poikilocytosis. Reticulocytes are decreased except after iron therapy. The MCV is low and the RDW is increased. The osmotic fragility is decreased. In most cases, the WBC count is normal, but granulocytes may tend toward a maturation shift to the right, for example, in hypersegmentation. Platelets are increased if the anemia is due to blood loss, or platelets may be decreased in advanced severe anemic stages. Serum iron is decreased. TIBC is increased. The percent saturation of TIBC falls below 15% in IDA. Serum ferritin is in equilibrium with tissue ferritin and is a good reflection of storage iron. The marrow of a patient who has IDA may have the following characteristics. First one, the normoblasts are smaller than normal with frayed margins. Number 2, storage iron is absent unless the patient is receiving iron therapy. Lastly, sideroblasts are decreased to lower than 20%. IDA must be differentially diagnosed from other microcytic or hypochromic anemias such as thalassemia, anemia of chronic disease, and sideroblastic anemia. Table 4-2 shows the differential diagnosis of the microcytic or hypochromic anemias using iron-related parameters.
I am Farima Pinaw and I'm going to discuss the disorders of iron excess. Iron excess, which means more than the usual or specified amount of iron. So these iron excess disorders result from the slow accumulation of excess amounts of iron stores in the tissues. This can result from the increased intestinal absorption, administration from transfused blood, specifically transfusion hemosiderosis, or the administration of iron complex drugs or vitamins. Disorders of iron excess includes general considerations, primary familial hemochromatosis, and sideroblastic anemia. So these are the general considerations. Plasma iron increases to 200 milligram per deciliter with 100% TIBC saturation. TIBC stands for total iron binding capacity. So macrophages can no longer able to store the iron once the percentage of TIBC saturation increases or becomes greater than 50%. Next is excess iron slowly damages organs, especially the liver, heart, and pancreas over a period of years. So, of course, too much iron can lead to life-threatening conditions. Next, hemochromatosis. Hemochromatosis refers to the diseases and symptoms that arise from chronic iron overexposure. So hemochromatosis is an inherited disease of iron metabolism. So iron poisoning in children can be fatal with as little as a 50 milligram dose. So young children are very susceptible to acute iron poisoning from accidentally ingesting iron pills or vitamins. Iron poisoning in children, as I have said, it can be fatal as at dose as low as 50 milligram. So primary familial hemochromatosis is a condition of iron excess that results from an abnormality in a gene on chromosome 6 that is closely linked with the human leukocyte antigen or HLA leucus. So in primary familial hemochromatosis, iron overload stems from an overall increase in absorption by the intestinal mucosal cells. So patients have chronically elevated serum iron levels, increased transferrin saturation, and iron overload in macrophages and hepatocytes. So sideroblastic anemia. Sideroblastic anemia, now classified as myelodysplastic syndrome or myelodysplastic syndrome. So it is a disorder of iron excess that is associated with defective synthesis of heme because of multiple enzyme defects and a result of iron overload in the mitochondria normoblast. So the patients with this type of anemia shows a hypochromic and often microcytic red blood cell morphology and is often observed with increased serum iron levels and decreased TIBC and significantly increased transferrin saturation. So the marrow shows greatly increased iron stores due to an increase in sideroblasts that is greater than 50% and an increase in siderotic granules per cell with the granules surrounding the nucleus. So, several variations of sideroblastic anemia have been noted as a hereditary. So, X chromosome linked type is found mostly in males and does not show up until adolescence. So, acquired idiopathic sideroblastic anemia can occur in either sex and has its onset in late adulthood. So, some of RBCs may be megaloblastic, and 10% of patients who have this type of anemia develop acute leukemia. So, pyridoxine responsive sideroblastic anemia can be treated with high amount of vitamin B6 to maintain normal hemoglobin synthesis. So, vitamin B6 helps make red blood cells. That's why it can maintain the normal hemoglobin synthesis. So, drug-induced sideroblastic anemia has been known to occur in patients chronically exposed to anti-tuberculosis drugs, lead, and chloramphenicol or ethanol ingestion.
So, heme disorders. In heme disorders, we have general considerations. This disorder of heme synthesis results in microcytic or hyperchromic anemia. Microcytosis is accompanied by an MCV lower than 80 femtoliter. The normal range is 80 to 100 femtoliter. So if it is lower than 80, it is already microcytosis. Because from the word itself, micro, it is lower or kanang gamay. So hypochromia is accompanied by an MCH less than 25 picograms. The normal range of MCH is 27 to 33 picograms, and by an MCHC less than 32 grams per deciliter, where the normal range is 32 to 36 grams per deciliter. So if less than 25 MCH and less than 32 MCH, which is less than from their normal range, it is already hypochromia. Next general consideration is that heme disorder can be caused by either enzyme deficiencies in the heme biosynthetic pathway or porphyrias or iron-related disorders. So, porphyrias, these are group of inherited or acquired disorders that can occur from the deficiency of one or several biosynthetic enzymes. Porphyrias or group of inherited or acquired disorder that can occur from the deficiency of one or several biosynthetic enzymes. These disorders result in ineffective hematopoiesis and hemolytic anemias. So these three are part of porphyrias. The rate of biosynthesis of the heme ring is controlled to a large extent by the reaction rate of the beginning enzyme. So we will be naming the specific enzyme further in this topic. So the acute porphyria are inherited enzyme deficiencies that begin with acute hemolytic disorders, while the chronic porphyrias are more commonly associated with solar photosensitivity of the skin and include either genetic or acquired conditions.
The rate of the biosynthesis of the heme ring is controlled to a large extent by the reaction rate of the beginning enzyme, the delta-aminolevulinic acid, or otherwise known as the ALA synthetase. The activity of this enzyme is reducible by some drugs and steroids. The enzyme is inhibited by a negative feedback of the completed heme ring. If the production of heme ring is inhibited somewhere along the pathway, there is a resultant decrease in the heme rings and an increase in the activity of ALA synthetase, which drives the pathway up to the point of the block and results in an increase in the intermediate compounds behind the block. And this enzyme plays an important role in the production of heme rings. So we have here acute porphyrias. So acute porphyrias are inherited enzyme deficiencies that begin with acute hemolytic episodes. So under acute porphyrias, we have three. First, we have acute intermittent porphyria. It is a hereditary autosomal dominant condition. So the clinical symptoms for acute intermittent porphyria, we have abdominal pain with vomiting, constipation, hypertension, peripheral neuritis, behavioral changes, and psychosis. So psychosis is a term used to describe when you experience reality in a different way to other people. So common example for this is hearing voices. So the common laboratory profiles for acute intermittent porphyria, we have slight elevations of bilirubin and alkaline phosphatase levels, increased urine ALA and porphobilinogen or PBG, and increased levels of leukocytes in the blood or leukocytosis. So the enzyme defects of the acute intermittent porphyria is caused by the decreased levels of uroporphyrinogen 1 and 3 synthetase, which results in increased production of ALA and PBG. Now we have here hereditary coproporphyria that is also under acute porphyrias. So it is also an hereditary autosomal dominant condition. So the clinical symptoms for this disorder is patients are either asymptomatic or they are initially seen with mild neurologic, abdominal, or psychiatric symptoms. Patients commonly have light sensitive skin because of increased levels of PBG. So the laboratory profiles includes increased coproporphyrinogen 3 in the feces, intermittent increases of coproporphyrinogen, ALA, and PBG in the urine. So enzyme defect for this disorder is patients have a deficiency in coproporphyrinogen decarboxylase activity. And last condition under acute porphyrias is the variegate porphyria. So it is an hereditary autosomal dominant condition that has a high incidence in the white population of South Africa. So the clinical symptoms for this disorder is symptoms are similar to acute intermittent porphyria with the additional symptoms of cutaneous lesions, which are caused by highly photosensitive skin. So the laboratory profile, there are increased levels of urinary ALA and BBG, but there is also an increase in the levels of porphyrin precursors that occur further along the pathway. So the enzyme defect for this condition is patients who have this disorder have a deficiency in heme synthetase, also known as ferrochelatase deficiency.
Hi everyone, my name is Ina Glasery Vietaas. So for today, I will be discussing the chronic porphyria under the heme disorder. So first, let us define what is chronic porphyria. So the chronic porphyrias are dermatologic diseases that may or may not involve the liver and the nervous systems and do not present with acute attacks. So under the chronic porphyria, we have a syndrome called congenital erythropoietic porphyria. So the congenital erythropoietic porphyria, or the CEP, is the rarest type of porphyria and is commonly seen in infancy. It is characterized by severe skin photosensitivity that may lead to scarring, blistering, and increased hair growth at the face and back of the hands. So the clinical symptoms of these disorders include redness of the skin, hemolytic anemia, severe skin photosensitivity, splenomegaly, and often fatal early in life. Next, we have the laboratory profile of the congenital erythropoietic porphyria. So patients often excrete red pigmented urine because of excessive excretion of coproporphyrin 1 and uroporphyrin 1. So enzyme defect, patients with this disorder show a deficiency in uroporphyrinogen 3 synthetase. So next one, we have the erythrohepatic protoporphyria. So the clinical symptoms of this syndrome is that the most common symptom of hepatic protoporphyria is a severe pain on sun exposure. Some patients may also be sensitive to some types of artificial light. So when the skin is exposed to the sun, patients first develop tingling, itching, and or burning of the skin. So this porphyria disease is a disease of early adulthood that exhibits mild skin photosensitivity. So the laboratory profile of this syndrome is that patients who have this porphyria demonstrate an increased level of red blood cells, photoporphyrin, and elevated levels of fecal coproporphyrin and photoporphyrin. So the enzyme defect causing this disorder is deficient activity of heme synthetase, which leads to overreactive ALA or ALA synthetase. Next one, we have the cutaneous hepatic porphyria. So the cutaneous porphyrias are all accompanied by elevated total plasma porphyrins and are specifically diagnosed by measurements of porphyrins in red blood cells, plasma, urine, and stool, as well as by genetic or enzyme analysis. So the clinical symptoms of this syndrome is that, or this disorder is that patients are commonly first seen with skin lesions because of solar photosensitivity. And next, we have the patients who have this porphyria have a medical history associated with liver disease, alcoholism, estrogen therapy, or ingestion of hexachlorobenzene. So, characteristic laboratory profile results include an elevated urine uroporphyrin with the type 1 isomers being excreted in greater amounts than the type 3 isomers. So enzyme defect, patients with this disorder have reduced activity of the enzyme uroporphyrinogen 3 decarboxylase. Next one, we have the lead intoxication. So, the clinical symptoms of lead poisoning include abdominal pain, constipation, neuropathy, absence of skin photosensitivity, ferrochelatase, and coprophenogen oxidase. So, how would you describe the changes seen in the blood smear of a patient with lead poisoning? So, one of the more common systems involved with lead poisoning is the hematologic system, where one can find anemia, red blood cells with basophilic stippling, which is one of the hallmarks of the diagnosis, and ring sideroblast on bone marrow evaluation. So, the anemia most often found is a microcytic hypochromic anemia, but this is likely due to the causes such as iron deficiency. So, the mechanism of the ring sideroblast is related to the accumulation of iron-laden mitochondria in the red blood cell precursors due to the inhibition of ferrochelatase by lead. So, next. So the characteristic laboratory profile associated with lead toxicity includes the elevated urinary ALA and coproporphyrin levels, increased RBC photoporphyrin, hypochromic red blood cells with basophilic stippling due to increased erythropoiesis, and toxic granulation in neutrophils. So, what are the possible treatments of lead poisoning? So, for acute ingestion, a gastric lavage could be performed to decrease the amount of lead-containing objects still in the stomach. So, cathartics can be given to rapidly remove lead already farther into the intestinal tract, and treatment successfully improves biochemical profiles. However, less data support the reversibility of neurocognitive effects of lead. So in all cases of increased lead levels, treatment should include identification and elimination of the source of the lead, behavior modification to limit ingestion, and nutrition maximization. So enzyme defect, lead inhibits several enzymes of the biosynthetic pathway. The most severely affected enzyme is the ALA dehydrase. So in here we have We have the structure, or what do you call this one, about the heme disorder. So, the heme synthesis begins with succinyl coenzyme A and terminates with the insertion of iron or Fe into the photoporphyrin IX or 9, photoporphyrin 9. Enzyme deficiencies in the heme biosynthetic pathway are related to the various porphyrias. So the name of the porphyria is placed by the enzyme that is deficient or dysfunctional. So there is a buildup of the biosynthetic intermediates in the pathway prior to the enzyme deficiency, which results in an increase in this metabolism in the blood, feces, and urine. Amino, you call this one? Amino-levonic acid. I think so. And that's it for today. That's my discussion. Thank you.